Hello, my name is Dr. Mark Walker. I'm the Chief Scientific Officer of the Outcome Science and Services Group at Concerto Health AI. Today I'll be presenting a short talk from some research we've conducted at Concerto on the subject of the performance of proxy measures compared with direct observation of progression-free survival. I'd like to thank my collaborators, Lisa Herms and Paul Miller, for their significant contributions to the study, and would also like to thank Concerto Health AI for its support of this research. The research presented here stems from work planned for presentation at ISPOR 2020 and reflects content from a poster that has been uploaded to ISPOR and that is available there. Background for this work is that there are multiple different effectiveness outcomes that are examined in real-world research, and in general, the aim of that research is to emulate findings that would be observed had the work been conducted prospectively. The endpoints of greatest interest are probably overall survival, progression-free survival, and perhaps tumor response. However, endpoints like progression-free survival and tumor response do not typically exist in structured form in electronic medical records, and they require human review and curation to definitively establish. Much real-world research is conducted in sources other than electronic medical records, however, and those sources may not contain the unstructured content needed to support curation. As a result, other endpoints, such as time to discontinuation and time to next treatment, may be adopted as alternative endpoints or proxy indicators for the underlying value of interest, progression-free survival. This approach has been widely used, but the performance of time to discontinuation and time to next treatment as proxy indicators of PFS is not well understood. However, correctly interpreting research that employs those endpoints may depend on an understanding of their relationship to PFS. The study presented here examined this question by using structured and unstructured electronic medical record data available through work that was previously conducted by Concerto Health AI. This work included human review and curation of unstructured EMR content, such as physician and nurse progress notes, lab reports, pathology reports, radiological scan reports, and other documents available in the electronic medical record. This work and the underlying research on which this study is based was retrospective, drawing on data originally collected as part of routine clinical care. We examined the research questions in a sample of metastatic breast cancer patients. Eligibility for the study is shown here. Patients were female, at least 18 years of age, and were diagnosed with metastatic breast cancer in 2008 or later. All patients in this study had hormone receptor positive, HER2 negative metastatic breast cancer. The sample size for this study was 378 patients. General descriptive methods were used to examine the study population. However, the outcomes of interest in this study, time to discontinuation, time to next treatment, and progression-free survival, were examined in the first-line metastatic setting using Kaplan-Meier methods and Cox regression analysis. The time origin, the point from which we measured each of these outcomes, was start of first-line therapy. The events themselves and the censoring points were defined following standard and widely used definitions for these endpoints. The details of those can be found in Table 1 in the ISPOR poster itself. We did, however, examine the effects of varying those definitions somewhat as a check on the sensitivity of the findings to those definitions. For purposes of evaluating the effect sizes that might be observed using these different endpoints, we classified patients in the study based on their receipt in the first line of an aromatase inhibitor containing therapy, an AI, versus receipt of a treatment that did not contain an AI. Details of those regimens can also be found in the ISPOR poster. I do want to note, however, that the underlying research did not examine outcomes based on treatment, so classification to these treatment groups was done specifically for this study to examine whether outcome effect sizes arising from treatment-based classification would vary across treatments. Analysis of outcomes from the 378 patients in this study showed a marked difference across the three endpoints. As shown in this Kaplan-Meier figure and in the summary statistics to the right, median PFS in the sample was about 9.1 months. In contrast, time to discontinuation was about 5.5 months, and time to next treatment was just under 6 months. The similarity of findings across time to discontinuation and time to next treatment is plainly visible in the Kaplan-Meier figure, and the difference between these and progression-free survival is also plainly evident. This indicates that in this sample at least, use of time to discontinuation or time to next treatment as a proxy indicator of PFS would significantly underestimate PFS. Likewise, if this research had been conducted with these patients using structured EMR data only, or perhaps using claims data for these patients with estimate of PFS as the endpoint of primary interest, the research would likely not have reached the same conclusion as research in which unstructured EMR data were available and human review and direct observation of disease progression were employed. The pattern indicates that patients must sometimes or perhaps often be changing treatments before occurrence of disease progression. That observation itself raises the question of why that would occur. Why would patients be switching treatment before they experience a disease progression? There are several possible reasons, but we think the most likely reason and the most common reason is treatment toxicity or tolerability. If patients are experiencing treatment side effects, they may discontinue their existing treatment and begin another, hoping for a more tolerable treatment, even though they have not yet experienced progression of their disease. If that occurs in more than a very small percentage of patients, we would expect it to yield the pattern we see here. Now, this pattern of findings may be deemed interesting, good to know, but an acceptable limitation of working with certain kinds of real-world data, as long as the pattern is understood. It may be that so long as we know this occurs, we can factor it into our interpretation of the data. However, if the pattern exists because some patients are experiencing treatment toxicity, it raises a question about what happens if the research examines comparative effectiveness and the treatments being compared do not have the same safety profile. In that case, it is possible that patients on one treatment might experience early switching at a greater rate than patients in the other treatment. If that occurred, then comparison of treatment groups on endpoints like time to discontinuation and time to next treatment might yield a different answer than comparison of those same treatment groups on progression-free survival. We examined that question next, and the figures you see here illustrate what we found. As noted earlier, patients were classified as to their receipt in the first line of an aromatase inhibitor-containing therapy, and this happened to divide the sample quite evenly, 179 in the AI group and 199 in the non-AI group. As shown in the table below and in the figure on the left, there was no significant difference between these patient groups in median progression-free survival. There is a nominal difference of about 2 months at the median, but you can see in the figure that that's mainly an artifact of group separation that was briefly present between months 7 and 10, but that was generally not present over the rest of the survival period. And the non-significant log rank test reflects that fact. The overall median PFS was around 9.1 months, with the two group medians straddling that value. The figures to the right for time to discontinuation and for time to next treatment show the shorter overall medians we observed on the previous slide, around 5.5 months and about 6 months, respectively. However, in contrast to the PFS analysis, these figures show a significant treatment effect favoring patients in the aromatase inhibitor group. The log rank test in both of these analyses were significant, and the survival curves exhibit clear separation starting at about 4 months and persisting to around 30 months. These median time to discontinuation and time to next treatment values for the AI groups were much more closely approach the median PFS for that group and suggest that fewer patients in this group discontinued or switched treatment before the occurrence of disease progression. In contrast, the median values for the non-AI group appear more divergent from the median PFS and suggest that more early switching occurred in this group. In addition to the interesting story these findings may tell about the treatment experience of these patients, they also tell a story about the endpoints themselves. Beside the fact that time to discontinuation and time to next treatment yield a different outcome overall than PFS, in this case indicating shorter time to event, they also yield estimates of treatment effect that differ from the story told for PFS. This suggests that if comparative effectiveness research were done in this population, using sources that do not include direct observation of disease progression and that rely on proxy indicators, such as time to discontinuation and time to next treatment, and assuming PFS itself is regarded as a more gold standard effectiveness outcome, then the research that employs the proxies will yield an incorrect estimate of treatment effect. There are, of course, important limitations to this research. First, and perhaps foremost, this is but a single study, and the question of interest here was examined in breast cancer patients only. It is possible that the findings in another study or in another cancer would yield different findings. We did conduct follow-up analysis with Cox regression, mainly to quantify the effect size as a hazard ratio, but we did not conduct group comparisons controlling for other demographic or clinical characteristics. The patients examined here were drawn principally from community oncology practices. It is possible that patients treated in other settings would receive different patterns of care and have different outcomes. Finally, the endpoints we examined here can be defined in different ways. Some of those differences are subtle and some may be less subtle. We conducted some sensitivity analysis around those definitions, and they seem to have little or no effect on the pattern of findings. However, that examination was not exhaustive. It is at least possible that alternative definitions of the endpoints would alter the pattern of findings we observed. There are a range of conclusions that can be drawn from this study. However, for us, the two key conclusions are, first, that in at least some cancer populations, time to discontinuation and time to next treatment will yield different endpoint values than PFS and may not be reliable as estimators of PFS. Second, that effect sizes associated with group comparisons on these endpoints may differ in ways that make time to discontinuation and time to next treatment unreliable as proxy indicators of the effect size that would be observed for PFS. We think it is likely that the mechanism that accounts for the overall difference in outcomes also accounts for the difference in effect sizes observed for those outcomes in treatment-based groupings as observed here. However, this is a subtler question and one that we're investigating in some follow-up research. Well, thank you again to my colleagues Lisa Herms and Paul Miller for their contribution to this research and to Concerto Health AI for supporting this work. If you'd like to know more, please visit the ISPOR website and have a look at our poster. Thank you very much.